Hello, it's Dmitriy again. Today we'll be going into Blueprints Psychiatry again for Chapter 11, talking about antipsychotic medications. Again, this is the 5th edition of the Blueprints Psychiatry textbook. There's a more recent 6th edition which is out there, which is more updated, has relatively the same content, but there is some differences. Regardless, let's begin. Chapter 11, Antipsychotics. Antipsychotic medications are used commonly in medical and psychiatric practice. As a class, antipsychotics have in common their blockade of dopamine receptors and their potential for serious side effects if used inappropriately or without careful monitoring. Most commonly prescribed typical first-generation antipsychotics and atypical second-generation antipsychotics are listed in tables 11.1 and 11.2. Their relative potencies, side effect profiles, and major adverse reactions are also described. Typical antipsychotics have also been called neuroleptics for their tendency to cause movement disorders. They are generally equally effective, although they differ in side effect profiles and potencies. Atypical antipsychotics have fewer extrapyramidal side effects at their therapeutic doses compared to typicals. Clozapine and perhaps other atypicals are more effective than typical antipsychotics for the treatment of refractory psychotic disorders. Indications. Antipsychotics generally are effective in treating the positive symptoms of schizophrenia, hallucinations, bizarre behavior, delusions, regardless of the actual diagnostic category, Table 11.3. For example, hallucinations in schizophrenia, in Alzheimer's disease, or secondary to cerebral toxicity or injury all respond to antipsychotic medications. Typical antipsychotics are thought to be less effective than atypical antipsychotics in treating the negative psychotic symptoms of schizophrenia, that is to say, amotivation, akinesia, affective blunting, social withdrawal. In addition to their role in treating psychotic symptoms, antipsychotics are used to treat bipolar disorder, some forms of non-psychotic behavioral dyscontrol, that is to say, organic brain syndromes, Alzheimer's disease, mental retardation, delirium, Tourette's syndrome, post-traumatic stress disorder symptoms, and transient psychotic symptoms as they appear in patients with personality disorder. Mechanism of action. The most prominent theory on the mechanism of action of antipsychotics is the dopamine hypothesis of schizophrenia. This hypothesis purports that dopaminergic hyperactivity leads to psychosis. Figure 11.1. Evidence supporting a role for hyperdopaminergic states in schizophrenia and presumably other psychotic conditions is as follows. Antipsychotic potency of traditional antipsychotics correlates highly with their potency of dopamine receptor blockade. Individuals with schizophrenia have an increased number of brain dopamine receptors, and dopamine agonist drugs, that is to say amphetamine, can induce or exacerbate existing psychosis. It appears to be clear that dopamine physiology is only part of a more complex underlying pathology. Abnormalities in the gamma-aminobutyric acid and the N-methyl-D aspartate receptors and cortical neural networks are present in patients with schizophrenia versus healthy controls. A comprehensive neurophysiological model of the disorder is being developed via the synthesis of a growing scientific knowledge base from a wide variety of international neuroscientists. So, basically the idea is the traditional hypothesis was the dopamine hypothesis, that dopamine is sort of this driving factor inducing schizophrenia and some of these other kinds of psychotic states. The problem is that there's other things going on at the same time, with GABA and the N-methyl-D aspartate receptors. So there's clearly some other things going on as well. And so even though they might be playing a major role or a bit, some sort of role in the disease process, it's not exclusively a dopamine issue. A third generation of antipsychotics is likely to be developed based on discoveries of the therapeutic effects of the gamma-aminobutyric acid, that is to say GABA, and the N-methyl-D aspartate modulation. Table 11.1, typical antipsychotics, aka the first generation antipsychotics. So we have drugs, therapeutic dosage range, potency, sedative, hypotensive, anticholinergic, and the EPS symptoms, the extrapyramidal symptoms. So typical antipsychotics, dopamine antagonists. We have thyroidazine, which is also called Mellaril, but thyroidazine. You normally have a 150 to 800 milligram dosage, potent for therapeutic dosage range. Potency is 100. Sedative is high. Hypotensive high. Anticholinergic effect would be high. EPS symptoms would be low for thyroidazine. What about chlorpromazine, which is also called thorazine, which is kind of confusing, but whatever. Thorazine, which is the standard name would be chlorpromazine. That has a 200 to 800 milligram therapeutic range. Potency is 100. Sedative is high. Hypertensive is also high. The anticholinergic is medium, and the EPS symptoms are low. Mesoridazine, also called Serentil, has a therapeutic range of 100 to 400 milligrams. Potency is about 50, so it's lower, right? Sedative is medium, so that's lower too. Hypotensive is medium, that's a little bit that's lower too than the other two we just mentioned. Anticholinergic is medium, and the EPS symptoms are medium as well. So they have some elevated EPS effects. What about melinidone, which is also called Moban? So melinidone has a 15 to 255 milligram dosage range, so that's a lower dosage therapeutic range. So we're kind of decreasing our therapeutic dosage range as we go down this list so far. Potency is 10, sedative is medium, hypotensive is low, anticholinergic is medium, and the EPS is high. So you kind of see this sort of gradient from the therapeutic dosage range being lower and lower and lower, the EPS effects being higher and higher and higher, and sort of these other additional effects being, lower as well. So again, so far, thyroidazine is on one end of the spectrum. It has a relatively broad and high therapeutic range, dosage range. It has low EPS, and it has relatively high potency, sedative, hypotensive, anticholinergic, right? For melinidone is the other end of the spectrum. It has relatively lower end therapeutic range, dosage range, low potency comparatively. Or maybe that's, the potency, there's a little B there. Let me read this B for a moment. Give me a moment. The potency is indicated as relative milligram dosage equivalence of thyroidazine is equivalent to 2 milligrams of haloperidol and should not be confused with efficacy. All typical antipsychotics are thought to be equally efficacious. Okay, what they're saying is is indicated relative milligram dose equivalence. Okay, so they're saying 100 milligrams of thyroidazine is equivalent to 2 milligrams of haloperidol. Okay, so they're saying, okay, gotcha. So I wanted to make sure I didn't confuse the two. So what they're saying is when you talk about melinidone, is that the potency of 10, presumably milligrams of melinidone is equivalent to 100 milligrams of thyroidazine. So really this is a lot more potent, I would assume, is what they mean by that. Because it's a lot smaller. And then these other effects are a lot weaker, except the EPS, which is much stronger for melinidone. So let's continue, though. There's more drugs than that. There's a lot of drugs. Perfenazine, which is also called trilofon, its therapeutic range is 8 to 32. Its potency is 10, so it's 10 milligrams versus the 100 milligrams for thyroidazine. Sedative, hypotensive, and anticholinergic are low, low, and low. Its EPS is medium. Loxapine, also called L'Occitane or Daxolin, is 60 to 100 milligram dosage for therapeutic range. Potency is 10 again. The sedative, hypotensive, and anticholinergic is medium, low, and medium respectively. The EPS is high for Loxapine. What about trifluoroperazine, which is also called Stelazine? Well, the milligram on that for therapeutic range is 5 to 20, so it's not too crazy. It's pretty low. The potency is 5. That's very low. Now, again, we're talking about 5 milligrams being the equivalent to 100 milligrams of thyroidazine. The anticholinergic, is that the order? Sedative, hypotensive, anticholinergic. So hypotensive, sedative, anticholinergic for trifluoroperazine we're talking about is medium, low, and low respectively, and the EPS is high. And all these rest are basically the same as that. Thiothixine, which is also called Navane, haloperidol, also called Haldol, fluvenazine, which is also called Prolixin, and Pimozide, I've heard that one before, is called ORAP. These are antipsychotics first gen. These ones are all basically the lower end of the therapeutic range in terms of what's acceptable. Their potency is they're very potent compared to thyroidazine. They all have relatively low to medium effects for anticholinergic, sedative, and hypotensive, but they all have relatively high EPS extrapyramidal symptoms. And I want to make sure that I'm saying this correctly. EPS, and I want to say, yeah, okay. I want to make sure I'm not confusing too. Extrapyramidal symptoms is the context of Parkinson's refers to the medication-induced movement disorders. They most commonly occur in Parkinson's patients treated with antipsychotics. Okay. So I just want to think about what causes EPS outside of the context of antipsychotics. What causes let's see. It says here EPS are movement disorders caused by changes in dopamine levels in the brain. Yes. Besides antipsychotics, they can be triggered by other prescription medications. Okay. So basically EPS is a consequence of antipsychotics. I thought it would have been induced by something else as well, but apparently it's really an antipsychotic thing. Maybe some other medications can do some of the same stuff, but that's beyond the point here. Regardless though, and that's another good point too. Let me go back in this a bit. What does EPS look like? No. So extrapyramidal symptoms look like involuntary muscle contractions, stiffness, and restlessness. You can think about akathisia, which is an intense subjective feeling of inner restlessness. Acute dystonia, which is a sudden, painful, and involuntary muscle spasm. Drug-induced Parkinsonism, which is symptoms that mimic Parkinson's disease. That's what I was thinking about. Okay, so Parkinson's disease, you have something that you can have something that resembles Parkinson's disease because it's anti-dopaminergic. Because when you have a Parkinson's disease, you have a dopamine deficiency, and so as a consequence, you can have these sorts of effects that resemble Parkinson's if you're taking anti-dopaminergic drugs. So again, you have resting tremor, muscle rigidity, stiffness, slow movements, shuffling gait. You have tardive dyskinesia from antipsychotic, which is something to be aware of. Involuntary, repetitive, and purposeless body movements, commonly involving facial grimacing, lip smacking, or rapid tongue movements. This typically develops after months or years of the medication use. And you should be definitely aware of that if you are going to be involved in psychiatry, because you could have a situation where the patient has one of those things, and you want to make sure you acknowledge that, because you don't want them to have that. You can present problems for the patient if you continue them on the medication and they continue having those symptoms, because at some point it might be hard to get rid of the symptoms at that point. If you keep them on the drugs for years and years and years, and they have the same sort of tardive dyskinesia, they might just be stuck with it at some point. So just be aware of that. It can lead to long-lasting problems potentially. Again, you could say it's not a big deal. Oh, their tongue does something weird. They grimace occasionally. But people kind of find it weird. People kind of find it potentially embarrassing, possibly. So just bear that in mind. Anyway, additionally, the action mechanisms of our current antipsychotics are often much broader than simple dopamine blockade, which accounts for the numerous side effects and the finding that their action in the brain is not well correlated with regions thought to give rise to psychotic symptoms. The atypical antipsychotic medications have prominent serotonin 5-hydroxytryptamine 2 receptor activity. It is unclear whether the serotonin activity imparts antipsychotic efficacy, but the activity may affect mood and anxiety symptoms in patients with psychotic disorders and helps prevent extrapyramidal side effects. Some atypical antipsychotics also appear to have mood-stabilizing properties in bipolar disorder. It is unclear whether the mechanism of these effects is related to dopamine, serotonin, or some other chemical mechanism. So here's table 11.2 for atypical antipsychotics. We have the drug and we have the therapeutic dosage range. So we have aripiprazole, which is also called Abilify, is 10 to 30 milligrams. Clozapine, which is also called Clozaril, which is 100 to 600 milligrams for the therapeutic dosage. Risperidone, also called Risperidol, 4 to 6, very, very low. Olanzapine, Zyprexa, is 10 to 20. And that induces a lot, and I think it's probably true for more than one, just that, but olanzapine is particularly known for causing people to want to eat a lot of food, become very hungry. Paliperidone, also called Invega, is 3 to 9 milligrams. Quetiapine, which is also called Seroquel, is 400 to 800 milligrams for the therapeutic dosage range. and ziprasidone, also called Geodon, is 80 to 160 milligrams for the therapeutic dosage. Typical antipsychotics, dopamine antagonists. The antipsychotic potency of typical antipsychotics and risperidone correlates with their affinity for the D2 receptor. Figure 11.2 is a schematic diagram of the proposed brain pathways affected by the typical antipsychotics. Dopamine-containing axons arising from the brainstem nuclei and the ventral tegmental area, which is the VTA, and substantia nigra project to the basal ganglia, frontal cortex, and limbic areas. Typical antipsychotics and risperidone strongly block D2 receptors. Blockade of the dopamine in the cortical and limbic areas results in reduction in the psychotic symptoms, whereas blockade of the dopamine in the basal ganglia produces extrapyramidal side effects. Although antipsychotics, especially lower potency medications, may have an initial sedative effect, their antipsychotic action is not immediate and takes several days to several weeks to peak. Table 11.3, indications for antipsychotic drugs. The effective and the possibly effective. So we have short-term use for less than 3 months. It's effective exacerbations of schizophrenia, acute mania, psychotic depression, brief psychotic disorder, acute delirium, drug-induced psychoses resulting from hallucinogens and psychostimulants, not phenylcyclidine, no. So that's kind of the broad what it can be used in the short term. Now what about possibly effective in short term? Well, it could maybe be useful for brief use for episodes of severe discontrol or apparent psychosis in some personality disorders. What about long-term use for more than 3 months? Well, it can be effective in long-term for schizophrenia, Tourette syndrome, bipolar disorder, Huntington's disease, chronic psychoses related to neurological disorders. Possibly effective long-term, it might be useful for delusional disorders, childhood psychoses, PTSD, or PTSD nightmares, okay, and flashbacks. So PTSD, nightmares, and flashbacks. So here's a little diagram. Let me read out the thing for you first. So figure 11.1, the dopaminergic diffuse modulatory system of the brain, the mesocortical limbic dopamine system arises from the ventral tegmental area and has been implicated in the cause of schizophrenia. A second dopaminergic system arises from the substantia nigra and involved in the control of voluntary movement by the striatum. So here's the thing too. When we think about Huntington's disease, we're thinking about the dopaminergic pathway related to the substantia nigra, because the substantia nigra has an issue of not producing enough dopamine in the context of Huntington's disease, okay? Parkinson's disease, my mistake. In Parkinson's disease, there's a deficit of dopamine-producing cells in the substantia nigra. However, for schizophrenia, we're talking about sort of this excess dopaminergic activity going on, maybe from receptors or something like that. But basically a dopaminergic activity excess in schizophrenia related particularly to the mesolimbic pathway. They say the mesocortical limbic pathway. There is an overall pathway involving the VTA, but I would say, if I'm not mistaken, in schizophrenia, the negative affect of schizophrenia, the negative symptoms of schizophrenia, that sort of flat, blunted affect you would see in schizophrenia, is actually a consequence of the mesocortical deficit of dopamine. And let me just confirm that, because I'm going off the dome right now. So take my words with a grain of salt. Is there a dopamine deficit? Okay, so this is what I looked up briefly online. So, yes, a dopamine deficit in the mesocortical pathway is a core component of the modern dopamine hypothesis of schizophrenia. Basically, we're talking about, there's this excess of dopaminergic activity in the mesolimbic pathway causing all sorts of positive symptoms like the psychoses, the hallucinations, the delusions, this kind of stuff. These are the positive symptoms. But the negative symptoms we associate with schizophrenia, the sort of flat affect you can think of a person with schizophrenia, that is a consequence, and that's more than just a flat affect, to be fair. Negative symptoms of schizophrenia also would be things like avolition, which is a severe lack of motivation, elogia, a poverty of speech, anhedonia, the inability to experience pleasure, anticipate enjoyment of things, asociality, they're asocial, they don't have a strong lack for, so they have a profound lack of a social drive or interest in interacting with others, affective blunting, that's the flat affect I was talking about before. Those are not because of dopaminergic excess in principle. Those are more related to a deficit of dopamine in the mesocortical pathway. This specific deficit is believed to be responsible for the negative symptoms like lack of motivation, etc., and cognitive impairments like poor working memory of the disorder. So that's the thing to be aware of, that it's not just this dopaminergic activity across the board that's so overactive, it's contextual. Mesolimbic pathway, dopaminergic excess and activity, you have all these positive symptoms. The mesocortical pathway, there's a lack of appropriate dopaminergic activity, and so you have these negative symptoms of schizophrenia. And so as you can imagine, when you take a first-generation antipsychotic where it's just simply a dopamine antagonist, there's nothing more to it than that, it really doesn't solve the entire issue. It might solve some of the positive symptoms, but I don't believe until you start getting second-generation antipsychotics do you really start actively trying to manage the negative symptoms as well. So second generations try to treat both if they can. It's, obviously it's not perfect, but the first generation's really focusing on just those positive symptoms we associate with the mesolimbic pathway because they are dopamine antagonists, or they have anti-dopaminergic effects, right? So here's just look. You can look at the graph. You can see the VTA, the substantia nigra. Remember, substantia nigra is also involved in Parkinson's disease because of a dopaminergic, a lack of dopamine producing cells from that region. You can see the striatum. You can see the frontal lobe. So frontal cortex, limbic structures, basal ganglia, dopamine, and the VTA, substantia nigra. So VTA, substantia nigra, giving off dopamine to the basal ganglia, frontal cortex, and limbic structures. This pathway is affected by the typical antipsychotics. Okay. Atypical antipsychotics, i.e. second-generation antipsychotics, serotonin/dopamine antagonists. At present, in the United States, there are 7 atypical antipsychotics. Antipsychotics are classified as atypical when they produce fewer movement side effects than typical antipsychotics. And again, that's probably connected to the fact that the second-generation antipsychotics are not simply trying to antagonize dopamine. They do more than just that. And so some of these more obvious EPS effects associated with antipsychotics, we were talking about this before, sort of. We said that, for example, schizophrenia, we're thinking about this dopaminergic excess and activity, but the Parkinson's disease is the opposite. There's this sort of dopamine loss. There's not enough dopamine activity going on because of the substantia nigra has an issue with producing dopamine. And so they're having sort of the opposite situation. So if you take an antipsychotic, which again is has a lot of this dopaminergic activity, well, then it's going to induce these sort of Parkinson's-like effects, which is like the EPS symptoms, the EPS, the extrapyramidal side effects. Make sense? And so the second generation stuff is not as crazy about those sort of effects, essentially. Antipsychotics are classified as atypical when they produce fewer movement side effects than typical antipsychotics. In addition to dopamine receptor blockade, atypicals block serotonin receptors of the 5-hydroxytryptamine 2 subtype. Figure 11.3 depicts the similarities and differences of the serotonin and dopamine systems. Serotonin receptor blockade conveys some protection against the EPS, the extrapyramidal side effects, and may impart antipsychotic efficacy. Risperidone is similar to typicals in that it is a very potent blocker of the D2 receptor with relatively less serotonin activity than other atypicals. Choice of medication. Antipsychotic medications are most commonly chosen for the acute treatment of psychosis in both mood and psychotic disorders. Choice of medication should be based on diagnosis, phase of the illness, prior patient or family member response, side effect profile, patient tolerance, likelihood of adherence in available form, that is to say, elixir or intramuscular depot availability. The oral preparations of the atypical antipsychotics are usually considered first line for acute psychosis. At present, clozapine is the only medication clearly shown to be superior in patients for whom other antipsychotics have failed. Now, this is an old edition of the textbook. I'm not sure if that's still true, but it might be. Because of the clozapine's serious side effects, however, it is not used until patients have failed at least 2 other antipsychotics. Intramuscular forms of aripiprazole, olanzapine, and ziprasidone are available and approved for acute agitation and schizophrenia. Fluvenazine, haloperidol, and risperidone are available in depot or other long-acting preparations, which are given intramuscularly every 2 to 4 weeks for maintenance treatment of chronic psychosis, chronic schizophrenia. So with the VTA, substantia nigra, dopamine going over to the basal ganglia, the frontal cortex, and limbic structures, while the raphe nuclei giving off serotonin is going over to the basal ganglia, the entire cortex, and limbic structures. So basically, the serotonin and the dopamine coming from the VTA, substantia nigra, and the raphe nuclei, respectively, they are going to be affecting a lot of the same areas: limbic structures, basal ganglia, and either the entire or just the frontal cortex. It says here, figure 11.3, pathways affected by atypical antipsychotics. So they're acting on the same places in different ways by messing with both serotonin and the dopamine. Choice of medication is often, but not required to be, guided by approvals that have been obtained from the U.S. FDA. Much prescribing is done off-label based on available research and clinical experience. The FDA approval process often lags behind state-of-the-art psychopharmacology. Approved indicate, which I, from personal experience, from my experience with working under a psychiatrist or doing rotations with a psychiatrist, I can attest to you that is a theme of sort of the regulatory system of approval and those other kind of stuff, and also for that matter, insurance coverage really does lag behind where the research is going on at the time, where the doctors are at and where the insurance companies are at and where the FDA is at is like basically two different places. The FDA approval process often lags behind state-of-the-art psychopharmacology. Approved indications have become increasingly specific, for example, specifying not only the diagnosis but also the phase of the illness for which a drug is approved, that is to say, the manic phase of bipolar disorder. The indications for some antipsychotics have recently broadened to include the treatment of various phases of bipolar disorder, even when there is no psychosis present. Aripiprazole, chlorpromazine, olanzapine, quetiapine, risperidone, and ziprasidone are all approved for use in the manic phase of bipolar disorder. Olanzapine, fluoxetine, in combination with quetiapine, are approved for treatment of bipolar depression. A major multi-center clinical trial is underway that aims to compare the effectiveness of the antipsychotics in order to provide evidence to guide treatment choice. The study, known as clinical antipsychotic trials of intervention effectiveness, is being performed and published in phases over years. The initial phases of the study have confirmed current knowledge that antipsychotics are only partly effective in populations of patients, particularly because of the intolerable side effects in both in typicals and atypicals. The study has also shown that typicals, represented in the study by the mid-range potency drug pervenazine, and the atypicals, with the exception of clozapine, have comparable rates of effectiveness as measured by rates of all-cause discontinuation. Less than one-third of patients remained on any of the initial randomized drug at the end of the 18-month study, either because the first drug was intolerable or did not work. The side effects of the agents, however, have been shown to differ markedly. Movement disorder side effects are common with typicals, and sedation or metabolic effects more common with atypicals. Phase 2 of clinical antipsychotic trials of intervention effectiveness revealed superiority of the clozapine over the other atypicals in terms of all causes continuation, with 44% of clozapine patients remaining on the drug at 18 months. Future phases will include the atypical aripiprazole and will look at the effect that patient support programs have on adherence and effectiveness. Therapeutic monitoring. Patients on antipsychotics should be monitored closely for adverse drug reactions. Metabolic and neurological reactions are particularly important. It is now recommended that one obtain a baseline body mass index (BMI) and fasting blood glucose prior to initiating an atypical antipsychotic because of the risk of weight gain and diabetes. Very true. Neurological disorders such as akathisia, restlessness, neuroleptic malignant syndrome, and extrapyramidal symptoms can happen with most antipsychotics, but are more common with typical antipsychotics. That is to say, first generation is more of an issue with that stuff. Although it's not absent in second generation necessarily either. Patients taking any antipsychotics should be carefully monitored for seizure activity, as all antipsychotics appear to have modestly lower seizure threshold. Individuals taking clozapine only must have frequent white blood cell counts to monitor for the development of agranulocytosis. So bear that in mind as well. Clozapine, think about agranulocytosis. Think about doing a white blood cell count, to monitor that. Clozapine must be discontinued immediately in patients demonstrating this potentially fatal reaction of agranulocytosis. Blood levels have generally been of little use in monitoring antipsychotic efficacy, but may be useful in assessing adherence. Haloperidol levels have some utility in patients who have side effects at low doses or who fail to respond to high doses. Clozapine levels are also frequently used to determine adherence and correlate efficacy with levels. Although approximately 40% of patients will not respond to a particular antipsychotic, non-adherence, either full or partial, is often the cause of apparent therapeutic failure. The duration of therapy depends on the nature of the severity of the patient's illness. Many disorders, such as schizophrenia, require maintenance antipsychotic therapy because of the serious sequelae associated with long-term antipsychotic use. Maintenance therapy should be used only after a careful risk-to-benefit analysis with the patient and involved family. Side effects and adverse drug reactions. Side effects of antipsychotics are a major consideration in physician prescribing. Patients who cannot bear the side effects of medications are non-adherent and suffer greater rates of relapse and recurrence. Certain side effects, such as sedation, can be useful to a patient with insomnia or severe agitation, but can also limit functioning. A comparison of side effect profiles for commonly used typical antipsychotics is provided in Table 11.1. Common side effects of typical and atypical antipsychotics are described in the information to follow. Further discussion of neurological side effects is found in Chapter 16. Anticholinergic side effects. Low-potency typical antipsychotics, that is to say, chlorpromazine, have the greatest anticholinergic side effects, such as dry mouth, constipation, urinary retention, and blurred vision. In some cases, anticholinergic delirium may occur, especially in elderly individuals, those with organic brain syndromes, or patients on or other anticholinergic agents. Because extrapyramidal side effects, for example muscle stiffness, are related to an imbalance between dopamine and acetylcholine blockade, the typicals with high acetylcholinergic activity and high antidopamine activity have low incidence of EPS. So basically, yes, they still have these sort of antidopaminergic effects, but they also have sort of these this sort of effect with the anticholinergic activity as well, and so basically they're kind of balancing it out, actually. So that's interesting. And that's why the second generation is not as crazy about the EPS, because they are balancing out their antidopaminergic activity with some anticholinergic activity at the same time. Or so the theory goes, I guess, right? Reduced seizure threshold. Low-potency typical antipsychotics and clozapine are associated with lowering seizure threshold. Seizures resulting from antipsychotic therapy are treated by changing medications, lowering the dose, or adding an anti-seizure medication. Hypotension, as we were talking about before, right? Orthostatic hypotension is particularly common with low-potency agents and risperidone. The hypotensive effect of antipsychotics is generally caused by alpha receptor blockade. Agranulocytosis. Agranulocytosis has been associated with most commonly with clozapine. Make note of that, clozapine agranulocytosis. Because of the potentially fatal nature of this adverse effect, clozapine distribution is regulated and requires a regular complete blood count, CBC, with absolute neutrophil count to monitor for neutropenia. Cardiac side effects. Ziprasidone, low-potency typical antipsychotics, particularly thyroidazine and mesoridazine, and risperidone may cause QT prolongation with risk of torsade de pointes. Nonspecific electrocardiographic changes may also occur with certain antipsychotic medications, particularly with clozapine and olanzapine. Clozapine can cause a myocarditis, which is rare, but most commonly occurs early in treatment. Metabolic effects. Although patients with psychotic disorders are known to have higher rates of obesity and diabetes mellitus independent of medication therapy, studies have indicated that atypical antipsychotic medications, particularly olanzapine, right, and clozapine is a monster apparently. Yeah, it's doing all sorts of things. But anyway, olanzapine and clozapine are associated with higher rates of weight gain, dyslipidemia, and may be associated with adult onset diabetes. Movement disorders. Movement disorders such as dystonia, extrapyramidal symptoms, akathisia, neuroleptic malignant syndrome, and tardive dyskinesia occur most commonly with high-potency typical antipsychotics, that is to say, for example, haloperidol, and are discussed further in Chapter 16. Other side effects. Skin and ocular pigmentation are common side effects of neuroleptics, as is increased photosensitivity. Thyroidazine can cause pigmentary retinopathy at high doses. Increased prolactin level and sequelae may also occur. Quetiapine may increase the risk of developing cataracts. And that is the end of the corpus of our chapter today. Let's read some key points about the chapter. Typical first generation and atypical second generation antipsychotics are used to treat the psychotic symptoms of a wide range of disorders. Typical and atypical drugs appear to be equally effective, with the exception of clozapine, which may be the most effective for refractory schizophrenia, but differ in their D2 receptor potency and side effects. Antipsychotics can have serious neurological and metabolic side effects and should be carefully prescribed and monitored. And that is the end of Chapter 11 on antipsychotic medications. So, if you've gone through the video this far, hopefully it was good use to you. Regardless, have a great rest of your day. Thank you, and goodbye.